Of Get Smart with Your Heart series, a World Heart Day focused initiative by Boehringer Ingraham and organized by Integrated Health and Wellbeing Council. So this initiative is aimed at generating awareness around heart health and cardiovascular health equity in India. And the topic for today is cardiovascular health equity in India, bridging gaps and expanding the access, for which we have eminent panelists here with us. We have Dr. Nishant Kumar Abhishek on our panel, who is the head of Department of Cardiology for Employees State Insurance Corporation, Bihar. Sir, welcome to the show.
Thank you.
We would also be joined by Dr. J. Pati, who is Deputy Director for Employee State Insurance, Odisha, and would also be joined by Dr. Trinath Mishra, interventional cardiologist. So let us get started with the discussion today. So, sir, as the topic of discussion is cardiovascular health equity, where do you feel that, we stand right now on providing equitable health around cardiovascular diseases? What are your views and your experiences while working as a cardiologist? And what are your general thoughts around equitable health?
Just to tell a briefing that I have been working as a consultant cardiologist for the past 2 years in ESIC Bihta. And Bihta is 25 to 30 kilometers away from Patna, the capital. And Bihar per se, as you know, is not a very developed state as health infrastructure, or for that matter, any infrastructure is concerned. So my endeavor to join that place was to start up cardiology in those parts of the sector where the cardiology is needed the most. The problem with cardiology is that we think that it should be dedicated towards districts and tier 2, tier 1 cities. But the reality is it should be catering even any populated areas that is beyond classical healthcare. So being in ESIC Bihta, I have seen the cardiology as per OPD grow from a 1 patient, 2 patient OPD during my initial monthly tenure to an average of 100 patients per day in my OPD in ESIC Bihta. The issue with cardiology is that fast and rapid resolution of symptoms according to a specialized person will always lead to better outcomes. The problems with cardiology that I have faced is that people still are not ready to admit to the fact that they can have cardiac diseases. And it's so rampant that being on a peripheral healthcare system, and I'm part of a corporate system in Patna also. I'm a consultant in Apollo Spectra also. So the gap is so massive that people should be venturing out to tier 2 and tier 3 cities to actually go for the equity so that maximum patients are benefited from specialized healthcare. And an ECG and good quality echo should be a part of every small place in India. That is what I think after working in quite a peripheral healthcare system. I must say that ESIC Bihta currently located, I can very well say there's no DM cardiology across India that is working in a block state, and Bihta is a block. The institute is important, but the situation of that ESIC Bihta is still a block. So I get constant patients, and patients are benefiting from the treatment. So it's very happy-go scenario, even if we are going down to the wire and going down to the basic healthcare.
Thank you so much for sharing this information, sir. And you are doing something really amazing, something very required. And I am sure the viewers that are watching would get inspired. The budding, students from in cardiology as well to follow your footsteps. So, how is the scenario like in the area that you work? As you said, it is a block state. Are there any specific heart-related conditions that are specific to your area that you feel are very common amongst Bihta or Bihar state in general that you come across that are, clinically different from other states, or is it similarly? If so,
No.
what kind of
Yeah.
disease you come across?
See, in our part of the world, already the Indian consensus is quite common regarding heart disease. We are fighting coronary artery disease and heart attacks in common sense to the maximum numbers in districts, tier 2 cities, in villages. So heart attack forms the basic chunk of cardiology cases across India, even in metros, even in small cities, and they need a rapid treatment, early treatment, and early diagnosis. Other diagnoses like infective endocarditis, like pericardial effusion with is water across the heart, and valvular heart disease per se. Valvular heart disease, congenital heart disease, and structural heart disease, and cardiovascular dysfunctions. These are very rampant, very commonly found in the high populated areas, and that should be targeted. Many a times, what we miss is the early diagnosis during these treatments. What is the general consensus about people is that if they get cardiac diseases, they will have to be operated or being managed at a very high center at cost that will preclude treatment to them. But that is not the reality. See, we have intervention cardiology, and I am an intervention cardiologist. I do pacemakers, I do interventions, but there are many drugs, there are many heart failure drugs, many medications that are doing equally good in those patients. The only difference that is making higher amount of mortality with heart disease is the total disregard to cardiac symptoms in peripheral healthcare system, and they are not ready to consult a cardiologist. That is still a problem. They will attribute any symptoms to gas, or any symptoms to being weak, or any symptoms to feeling generalized weak, but they will not consult a cardiologist. This is the general consensus. And I'm not talking about a peripheral health center. This is the quality of reality, even in Patna. The good quality people, even if they develop some kind of symptoms, they will continue hiding that symptoms. And somehow we are missing the bus if we are hiding symptoms. So my would be there lots of cases. The only point that I will like to emphasize again and again is rapid diagnosis, early treatment.
Thank you for sharing that, sir. And as rightly said, that you have observed some sort of resistance in reaching out to specialist cardiologists for signs related to heart health. So, can you, for our viewers, make it simple to understand at what key symptoms that they face they must go and visit? Because I am sure those who are watching this show, if they are from Bihta or Bihar, would want to know what are those points where you must visit your cardiologist or specialist and get checked, should not ignore those signs and symptoms.
Yeah, just to start with, I like to say that common things like people should be worried about their blood pressure levels. People should be worried about their diabetic status post an age of 30, 35, 40. Earlier it was 50. Now I think 40 or 35 should be the age. Okay. Then secondly, if anyone is happening to have the classical symptoms that we face amongst cardiac patients, that is shortness of breath while walking, shortness of breath while heavy activity, chest pain, central chest pain that occurs on activity, any pain which radiates to both arms or throat, that can be due to cardiovascular disease, palpitation, unnecessary palpitation, feeling of your own heartbeat, leg swellings, loss of consciousness, sudden loss of consciousness, and then again achieving consciousness. These are 5 to 6 cardinal symptoms that we learn from classical cardiologists from basic textbooks. These are not part of rocket sciences. These are 5 to 6 symptoms. And any person pertaining to these symptoms should consult a cardiologist, should consult a primary physician as such. And if at all they are not resolving, the symptoms are not resolving, they should consult a cardiologist, get an echo done, get an ECG done. The point is with India is that we have revolutionized ultrasound abdomen in every periphery center, but the same needs to be done with ECGs and echoes. There should be more of ECG readers across India, more of echo readers across India. It should be more rampant. These tests should be more rampant across the subset in India.
Thank you so much for sharing that, sir. So, as you were saying, that there is some sort of resistance.
You're not audible, ma'am. You're not audible.
Yes. So, as you were saying, that there are some resistance amongst people when they want to reach out and in order to go and get checked from a specialist cardiologist for any of these signs that they are commonly seeing. So, what do you anticipate being the reason for these resistances or, unwillingness, if we say, to reach out and get checked from a specialist? Is it some socio-cultural reasons, or is it some sort of fear from going, or is it some sort of distrust amongst the medical fraternity that they feel? What could be the reasons that you have observed, or is it simply lack of awareness?
No, it's as you said, you have actually mentioned out all the probable reasons. So it's more of multifactorial. It's more of multifactorial. People in the first place don't like visiting cardiac heart doctors. People don't like it. They don't want to face cardiac doctors. Secondly, they always fear that something big will come up and they will end up not getting treated into some of those territories, like going for an angioplasty or going for a bypass, and they still they fear all these things. But the reality is science has progressed a lot. People do good on medications, people do good on operations, and people do good on bypasses, angioplasties, pacemakers. The problem with, as you have clearly mentioned, it's multifactorial. Cost is prohibitive. Cardiology treatments is still quite referral based, quite corporate based. Government systems are trying to catch up with the scenario. We have a big population to cater to these things because the subset is huge. The cardiac patient subset is huge. There's a long waiting list in our setups, and all the centers are not equipped accordingly. See, as I'm working in ESIC Beta, I'm continuously trying to put in a cath lab in there, but the reality is it'll take time. It's take its own time. In the meantime, all the patients are catered to according to OPD treatment and emergency treatments. But those cath labs regarding cardiac technicians and all those things are big problem. It's multifactorial, but patients do fear cardiac diseases. That's the reality, and that amounts to certain amount of negligence on the patient parts. Certain amount of, I have felt that in my high volume practice across the medical college, that people don't want to listen to the fact that they can have heart disease.
Yes, sir. As rightly mentioned, they do not want to hear that they are suffering from something very major. And I believe it could be because of how we are tuned from the beginning with the influence of media or movies per se, that whenever you go and whenever you get a heart pain, it's probably a heart attack. And that awareness around the various different aspects of heart health is also very required. So, as you were saying that you are working towards expanding a cath lab into the area, can you please highlight, how the institution is working to expand access to high quality cardiovascular care, especially in areas like Vihita that you are working, and what other initiatives that you are part of helping to expand the access and equity to cardiovascular care?
First thing first, as you said, that institutes or for that matter centers with specialist cardiologists should be there in every district. The point is the healthcare is still not accessible because of multifactorial reasons. Doctors want to spend their life in metros. Okay, so that is also a limitations. There's many sociological concerns, economical concerns, many of facts are there, but in reality, institute should be there on every district wise with a consultant cardiologist working there, and that would be like a dream come true. Because if you think that we can do away with referrals with cardiology, I don't think that would be the successful way of treating cardiac patients. Because if we just put on being referrals into 2 to 3 cities of every state, we'll keep losing patients. We'll keep losing patients, and especially in emergency condition. And where elective treatments are concerned, OPD treatment is concerned, then we have state-of-the-art institution all across India. Be it private, be it government, we have state-of-the-art institution all across India. But on the root level, there should be specialists, there should be basic institutes running cardiac clinics. That is what I have faced, and what I have seen. Because I am working in an area, I'll be honest, that's a very tough area to work. That's a very tough area to work. People are not ready to listen to the fact that they have cardiac issues. But when they are started on medication, they start feeling better, their negligence goes. And I have a good follow-up of around 2,000 patients in ESIC beta, and luckily with my association with ESIC beta, I've noticed they have great medications coming up to ESIC beta, which comes for totally free. So I don't know how government does that. I actually don't know how government does that, because those medications are out of bounds for even city people. People in Bihar don't actually believe that there are some drugs which are actually being supplied in ESIC beta on free basis. Still, the knowledge is less, the awareness is less, and people don't cater to those problems. Because we have come across, when we were treating heart failures or myocardial infarction or old heart attacks in 2015, and now in 2023, the horizon has completely changed. We have medications, we have added interventions, which are the heart failure patients and heart patients are doing much better in these 6 to 7 years. The only thing, again, I'll try to repeat, is early diagnosis, early treatment.
Thank you so much, sir, for sharing that. You being a seasoned interventional cardiologist with ESIC Beta, and also recognizing that these are the areas where gaps are there, and also recognizing how people have this fear and lack of awareness around cardiovascular diseases and seeking professional help at the right time. Are there any initiatives regarding public health awareness as well that you are involved with, or that ESIC Beta has in plan or is working on? If so, we would want to know.
The point is, there is multiple healthcare meetings that are done primarily by the cardiac, by the ESI team to multiple centers. They are reaching out. They are reaching out to patients, reaching out to peripheral health systems, the smallest units of health systems, and they are doing that. But creating an institute and coming up with a cardiologist is sufficient to actually bring in patients. Cardiac patients will end up going to those institutes if you are getting cardiac treatments. The problem being, if they land up in those centers and they don't have cardiac care, then we are at loss. Otherwise, cardiac awareness is something, it's rampant. You are adding to it. People know the facts that cardiac treatment should be taken. Post-COVID era, everyone is coming up with internet. Their knowledge is going beyond our expectation also. Sometimes that becomes a problem in handling patients in clinic, because people are informed. Everybody has internet connections. Social media is rampant. So we are coming up with the solution. I am working in the most backward state currently in healthcare, but people are coming, they know things. It's not the problem that they are not knowing things. It's just the problem is there should be more acceptance towards the disease rather than running away from the disease. And that is something which can be predicted with cardiac patients, and outcomes do wonders. Plain adherence to treatment, plain adherence to simple drugs, plain adherence to intervention procedures when needed, early diagnosis, early recognition of cardiac symptoms, early recognition of pediatric cardiology symptoms, pediatric cardiology interventions. can do wonders, and there are many referral centers for those things also. But primarily, my whole point would be that we are doing good as a cardiac centers, and people are coming up with good responses.
Definitely, sir. You are doing amazing work at your center, and also with a kind of response that you are getting with all the patients and etc. You are impacting hundreds of thousands of lives altogether. So let us talk about interventional cardiology a little bit. Could you highlight some of the recent advances in minimally invasive procedures or technologies that have significantly improved the outcomes of the patients with cardiovascular conditions?
See, the biggest thing is not recent. I think it should be still inculcated into real world. I was once with a conference a few months ago, and there was this intervention cardiologist in Mumbai who invented the procedure of primary angioplasty for myocardial infarction or heart attack. And he mentioned that he is the reason that we intervention cardiologists have to wake up at 2 a.m. in the morning for treating a patient of heart attack. So that is something that is across the treatment horizon for the past 20 years. But still the penetration is very poor, ma'am. It's very poor. Treatment of acute heart attack or STEMI, as they say, myocardial infarction, with a primary angioplasty is the way to go. Our center should be handling primary angioplasty. Government centers, private centers, they should be taking up primary angioplasty. The recent advances are high-grade valvular interventions that we are taking, like TAVR and mitra clip. These things are still something for more of an academic purpose than in real world. The real world data, according to me, primary intervention, primary angioplasty for myocardial infarction, and pacemakers for early complete heart blocks. So these are something which we have in cardiology over the past 30 years. But these two things should be penetrated across the spectrum. And there are many things that is coming up. Like, as we said, we are looking forward with high-grade interventions, newer interventions. But they are quite restricted to very less places. And the patient subset is also very less.
Thank you so much, sir. So we would also want to know, what lies ahead in providing, cardiovascular equity in the area that you are working. What would you feel would further help in bridging the gaps and expanding access for cardiovascular care, which is our topic of discussion. So in your opinion, what are the gaps apart from the ones that we discussed, which is from the patient's perspectives? Are there any other gaps that you feel need addressing from government's point of view or from clinicians' point of views you have come across?
Still, the number of specialist cardiologists across India, post-intervention cardiologists, is quite less. Okay, the numbers of seats are quite less. The super specialized domain is quite less. Not to rule out the primary physicians, they are doing great work in India, but there should be more penetration of super specialists across cities, across districts, across tier 2, tier 3 cities. Things should be made conducible for work in those places, for professional satisfaction of those doctors, and then we can do wonders with cardiology. There should be, my dream as a cardiologist would be cath lab in every district of India.
Thank you so much, sir. So, would you feel there is a marked difference in the, diseases that you observe around cardiovascular health in the marginalized or vulnerable population compared to, the healthier population of Bihita, or is it similar when it comes to cardiac health?
No, there are some differences. Of course, there are some differences, like rheumatic heart disease, valvular heart disease are more of a disease of lower socioeconomic strata, whereas heart attacks or coronary blockages are more towards the higher strata of society. But in real world scenario, the things are quite overlapping. Infective diseases are more towards this poor socioeconomic strata. The amount of burden of coronary artery disease, though in the city population is more, but many a times undiagnosed diabetes and hypertension leads to more cardiac diseases in the poor strata also. So just to say that rheumatic heart disease, valvular heart disease, and structural heart disease, like those diseases dealing with holes in heart and all, congenital heart disease, babies born with heart diseases are more common, found in the lower socioeconomic strata, and diseases related to lifestyle, smoking, diabetes, stress, heart attacks, more towards cities. But the data is, again, I said, overlapping.
Thank you so much, sir. So, as you were discussing that lifestyle diseases, which cardiovascular diseases come under which, but also includes diabetes and heart diseases, are more common in the higher economic strata population, similarly to how it is observed in the country, the ratios. So, is it how common is these conditions of obesity and diabetes in Bihita area, and as it probably most often overlaps with cardiovascular health? So, are these three conjointly seen similar to how it is seen in the overall Indian population, or is it marked more high in your area? How is it like?
My observation won't point towards an increased percentages of those patients in my area. I think it's more of a uniform. Indians, earlier Western population used to be the target population of heart disease in the early 80s, 90s, 2000s. But currently India is the capital of heart diseases, and more or less Indians are getting on a higher BMI side. More obesity is observed nowadays with the lifestyle of Indian people. So we are just the capital of heart diseases currently, with diabetes and heart diseases. The numbers we don't have that much of peripheral reporting of cases, but this would be a conjecture that I don't have data actually to prove that India is, but we have the numbers, and a lot of them are going undiagnosed, unregistered. So obesity is a reality. Indian lifestyle is a reality. Food is a reality. But that needs to be tackled. All those things need to be tackled.
Definitely, sir, very rightly pointed out. So now that we are coming into the very insightful discussion with you today on cardiovascular health equity in India, bridging gaps and expanding access for our Get Smart with Your Heart series, what would be your key takeaways for the audience that is viewing for getting smart with their heart?
I'd like to sum up that don't be paranoid about heart diseases. Okay, we are living with in a world where diseases are a reality. Okay, but neglecting symptoms should not be there. Remain healthy, remain lean and fit. Indulge in some kind of activity. Take away things like smoking, stress, or any personal issues that is hampering your life. Okay, be involved in some kind of active sports. If you have hypertension, diabetes, never neglect those symptoms. If you smoke, stop smoking. And if you have any symptoms, as I earlier pointed out, never feel shy to consult a cardiologist. A simple ECG, simple echoes, 2 or 3 drugs will actually prevent a possible catastrophe. Don't think about getting operated on you. Don't think about landing up with an angiography or an angioplasty or bypasses, all those things. Many a times, those things cannot be predicted by any doctor, or for that matter, anyone. Landing up with a heart attack cannot be predicted with certainty. But if the symptoms are neglected, that is something where should be working more on a population basis, maximize penetration of cardiac healthcare to every possible nook and cranny of India, and that'll be the best thing. We'll have better outcomes overall and overall well-being, healthy heart.
Thank you so much, sir. So thank you for taking out time from your busy schedule for imparting us with wealth of knowledge and information. We thank Dr. Nishant Kumar Abhishek for joining us today on this very insightful session on the topic of cardiovascular health equity in India, bridging gaps and expanding access, an initiative of Integrated Health and Wellbeing Council being powered by Boehringer Ingelheim for the World Heart Day Awareness Series. Get smart with your heart. I would also like to thank our partner for partnering up with us for this brilliant initiative for imparting awareness on cardiovascular health. Thank you so much. We would also like to thank our viewers for staying with us till the very end. I hope the session was as insightful for you as it was for us. With that, we sign off now. Stay happy, stay healthy. Thank you.
Thank you.